CataractCoach.com, case 350 for this young surgeon. How are your skills compared to this, and what can be improved here? We have an anonymous resident who's operating. You'll forgive the video quality. This is the way we got it. I tried to alter it in post-production here to get it a little bit better, but it's pretty reasonable. I think we can learn a lot from it. There's an anonymous resident who's going to do a divide and conquer technique. So let's look at everything first. So I can see that there's an ink mark there temporarily, so maybe a toric lens or astigmatic treatment coming up. I can see that the lashes are beautifully sequestered and the lid margin is draped appropriately. I like that. The eye's in good position. Little trypan blue dye in there. Remember the eye position, I want the iris parallel to the floor of the room. And it looks like we've achieved that. Trypan goes in, looks like maybe diluting it down now with some anesthetic, perhaps some sort of free lidocaine with BSS. And now here comes a dispersive viscoelastic. Nice fill there, beautifully done. I got all the air bubbles out. I like that. And you can see that it's a real cataract, some cortical changes there. I'm sure some nuclear and a big PSC plaque right there in the back. So here holding the paracentesis with one tine or arm of the forceps inside the para, one out. That's reasonable. Not my technique, but I don't mind it. And the incision, actually is pretty good. It was made very quickly, but the incision's pretty good. I think the architecture is reasonable, good tunnel length, good architecture. I'll take it. Now let's see the rhexis. So starting the rhexis. Now an important thing on the rhexis, you'll notice this is a good job here. Don't cut out to the full radius. Cut out to a half or 2/3 of the radius. And then grab the capsule and spiral it out to the desired size. Because if you cut out all the way to the size of the radius that you want, you may not be able to get the appropriate size. You may oversize it. So nice technique here. I like these fancy forceps. These are really fancy. Micro forceps that have a ruler built on the tip of them. The rhexis ruler, very nice. So completing that rhexis, I like the rechecking to make sure it's an appropriate size. Good technique, floating in the incision. That looks like a really nice rhexis. I'm going to take it. That's a beautiful rhexis. That's a great job. For 350 cases in, I'll like it. I like it very much. So nice looking rhexis there. Let's see the hydrodissection here. Using a specialized cannula. I like that. That's reasonable. And let's see, going under the edge here. And let's see, do we get a fluid wave? That's a good fluid wave. Pretty good. And let's go the other way. Let's see another fluid wave. Right. You know our favorite saying, if it does not spin, you will not win. I think this is going to spin, but did we spin it? Maybe not. So one thing I'd encourage you is spin the nucleus. I know you had some good fluid waves there, but give it a little spin. It'll make life a lot easier. So now it looks like a phaco probe in the right hand and some sort of ball tip chopper in the left. And getting a groove going on. Let's see the groove. So pretty good groove. I like how it's deeper in the center, shallow in the periphery. I'd encourage you to make the grooves longer though. You're starting pretty good in the subinsular space. Okay to go under the rhexis nasally there. That's okay. And so now, after the groove's made, are we going to crack already? Let's take a look. So coming on the crack, fingers a little bit too much in your view. See that left hand, maybe middle finger in the view? You want to keep that out of your view. So it looks like there's some sort of crack there. And then now what are we going to do here? Chop? Okay, I like it. So actually it's not even a divide and conquer. It looks like a stop and chop technique. Very nicely done. And taking out that piece. I like the two-handed approach where the second hand is helping to bring the piece out of the capsular bag. And that chopper has that ball tip. Now, you can use any instrument you want, but I think 350 cases using a ball tip chopper is okay. Once you kind of graduate a little bit more, you'll probably move away from the ball tip chopper. It just kind of hinders you and doesn't make life too easy. Actually, it prevents you from doing other techniques such as like a vertical chop or a combo chop, etc. You're kind of tied into doing just this horizontal chop. So, but good job removing those two pieces. Notice how the eye's staying in primary in this case. So good job in doing that. And then this piece coming up and then another sub chop. Very nice. So the title slide here was actually wrong. Remember, I'm watching this for the first time with you. I just kind of sped through it and I thought it was a divide and conquer because I saw the groove being made, but no, it's stop and chop. But we'll leave that title slide just so that other people can be fooled until they actually watch the video. So now cortex removal is going to be next, but right now for the epinuclear shell, that's a nice technique, nice and slow. Remember, there's a good way of flipping over that epinuclear shell just like that, and that gets it out easily. Chopper in the safe position, prevent the capsular bag from coming up. Very nicely done. So for 350 cases, I think you're doing a fantastic job. You're really putting in a lot of effort. Probably the most important thing, or the biggest clue to me that you'll be a fantastic or very accomplished surgeon in your future, is what? That you submitted the video. You care enough about your surgical technique that 350 cases in, you want some feedback, you want some criticism, you want something constructive to say, hey, here's how I can become better. So let's talk about the case. What would I have done differently in this case so far? I probably wouldn't have held the paracentesis with the forceps arm inside of it, because that may damage the tissue, but that's not a big deal. I liked your incision. Maybe slow it down a little bit. Maybe barely nick the limbal vessels if you can. A totally avascular incision will never heal up. Your rhexis is pretty darn good. I'll take it. That was a beautiful rhexis. The stop and chop technique was very good. You may have an easier time cracking the nucleus if you have the grooves are a little bit longer, but you had a beautiful technique and it worked well. And then your chopping was really quite nice. So now cortex removal was clean. I like the epinuclear flip that you did. Here's delivering the lens. Looks like a single piece of acrylic lens going in the capsular bag. That's going in pretty easily. Let's see the technique here. Oh, it's a toric lens. Good job. Nice. Now I see why you marked the cornea. And so let's see, delivering the lens. Make sure that goes in the bag. So just using the IA probe to do that, that's fine. And then let's make sure you go behind the optic, though, to remove viscoelastic. If it's a toric lens, hey, good job. I like it. Right, with a toric lens, you need that posterior aspect of the optic to touch the posterior capsule so it stays in position, doesn't rotate. So very nicely done. Just using the IA probe to rotate it, I guess that's appropriate. You may want to kind of upgrade here to using both hands. Keep the IA probe in the eye and the eye inflated and maybe use that a little bit, but also use a chopper on your other hand. You may have a higher level of accuracy in getting this thing rotated. And so that chopper, I find a lot easier and more controlled to get that lens rotated appropriately. Pretty good, I'll take it. So look at the optic and the rhexis, good size of the rhexis, about a 5 to 5.5 millimeter rhexis, overlapping the optic for 360. Fantastic, I like it. So good job. This case, you are really making good progress. If this is your 350, I'm really proud of you. And I can't hardly wait to see your case number 1,000. So please submit that in the future. So there now you can see the outline of the architecture of the incision. Actually a great incision. Again, I would have just barely hit the limbal vessels a little bit more. And then I'm not sure exactly how we're lining up or marking the toric axis or where it needs to be. But looks like you're happy, then I'm happy. And you got it in an appropriate position. And notice how the two Purkinje images, the first and fourth Purkinje images, are lined up beautifully in the center of that optic. That means the eye's in primary, and he's holding the eye in primary, staying in primary the whole time. Again, you've gotten past the hard parts of the learning curve, and now's the time for you to really shine. So beautiful job. Keep up the great work, and congratulations for so much progress and for the future that is to come. Thanks for watching these videos. Be sure to check out the website too, CataractCoach.com. You'll get the full text and the graphics and the photos, plus the videos. And if you sign up for a free daily email, we'll send all of that to you in your inbox every day for free. Come on. CataractCoach.com. Check it out.